It's sort of a disease management that's taught as though it's very simple and textbook. And in fact, there's nothing textbook about it. Patients with type 1 diabetes who are struggling with more calorie restriction and in particular carbohydrate restriction may look like they have absolutely ideal, spot on glycemia. And so from an endocrine standpoint, they go under the radar. But from a health and nutrition standpoint, their bodies are screaming.
Hi, Dr. Anne Goebel-Fabbri. Just to kind of get started, I was wondering if you could give us a brief overview of your career to date.
I'm a clinical psychologist with a specialty in what we call health psychology. I have a very, very niche kind of specialty in both type 1 diabetes and type 2 diabetes. Much of my research career has been focused on two main issues. One, eating disorders in type 1 diabetes, and the other, healthy weight loss strategies for wellness in type 2 diabetes. I worked at Joslin Diabetes Center for 16 years, affiliated with Harvard Medical School. And since 2015, I've been running my own private practice in psychology in the Boston area.
What would you say are the most common reasons why people develop disordered eating when they have diabetes?
There's a lot of speculation on that. This is only in women. We don't know yet about men because men are only more recently being studied, men with type 1 diabetes. The statistics on women shows that women with type 1 are about 2.5 times more likely to develop an eating disorder than women without type 1. We speculate that there are issues pertaining to the disease management itself, which make people more prone. And of course, the disease is one in which there's a constant need to focus on food and focus on portion size and carbohydrate counting and its impact on glucose and its impact on weight and all of these things on such a micro level of detail that we speculated this relentless pursuit of trying to get on top of it. And of course, the way that we teach diabetes management is aimed at the things that are under our behavioral abilities, right? So there are only certain things that we're able to manage, being what is it that we're eating, what doses are we taking as far as insulin goes, and how much are we moving our bodies. And beyond that, there are all these other variables that we don't teach people about because they're not anything that we can behaviorally change. It's sort of a disease management that's taught as though it's very simple and textbook. And in fact, there's nothing textbook about it.
I was going to ask as well how this looks different to people who don't have diabetes.
One thing that most of the eating disorders have in common is that there's a strong preoccupation with a thin body ideal and with weight loss at any cost. So weight loss to the point where it's either starvation and therefore medically dangerous, or it's elevated glucose and therefore medically dangerous, or it's binging and purging and therefore medically dangerous. So all of these various things where the pursuit of thinness becomes so powerful that it takes over control of the person's health, basically.
That makes it really hard for people with diabetes then, because there's people who have diabetes who might also be overweight, right? In order to help their diabetes, they might need to lose weight, but then how do you lose that weight and not make it become disordered eating?
Absolutely. It's a very, very fine needle to thread. And I think it's becoming even more complex now that we have the GLP-1 medications like Ozempic and Mounjaro, which are, of course, incredibly beneficial to some people with type 2 diabetes and even type 1 as well, but can go overboard. Yeah. So they have to be handled very delicately and carefully.
Could you give me examples of what disordered eating in diabetes might look like on the surface?
One of the problems with identifying eating disorders in general, even outside the area of diabetes itself, is that we tend to think there's a particular look. So an emaciated body frame, oh, that must be anorexia. That's an eating disorder. But for example, bulimia nervosa or atypical anorexia may be happening in a body that's either a healthy weight or even an overweight body. And so it's not the size itself. It's really about what is happening to this person in terms of their nutritional status. Are they eating enough and in a healthy enough way for what their body's energy needs are? And how are they doing that in such a way that keeps them going in a healthy status?
Yeah.
So now when you flash forward to the world of type 1 diabetes, it can take on many different forms. The most commonly studied eating disorder symptom with type 1 is insulin omission or insulin restriction. So people who are intentionally running their glucose levels high in order to purge calories through urination. And they may do that in the context also of calorie restriction. They may do that in the context of binging and other forms of purging, or they may use that symptom exclusively. Whether or not that results in an emaciated body may or may not happen, but that's going to be for the endocrinologist to notice, right? Not necessarily family members or friends. On the flip side, patients with type 1 diabetes who are struggling with more calorie restriction, and in particular, carbohydrate restriction, may look like they have absolutely ideal, spot-on glycemia. And so from an endocrine standpoint, they go under the radar. But from a health and nutrition standpoint, their bodies are screaming. So it can look both ways.
Generally as well, more and more people have access to technology and data. It feeds the need for control, right?
I'm so glad you used that word, because I'm sort of on this one-woman mission to eliminate the word control from diabetes vocabulary, but it still is part of the way people discuss blood glucose. And the reality is we don't control blood glucose. What we're decent at is managing blood glucose. That's a very different concept. But when you think about, again, what do the eating disorders have in common? They also have in common this feeling of exquisite control and then lack of control. Control by restriction and lack of control by binging. And control, again, by purging and lack of control. So this whole sort of back and forth. And I think oftentimes there's speculation that one of the risk factors for the emergence of an eating disorder is a sense that one's life is out of control. And this becomes a way to clamp down and feel more in control.
Maybe there isn't enough training. It might not be the biggest issue that comes up, right?
And also sometimes very well-meaning clinicians can look at this person's data and the data look fantastic, right? Near normal blood glucose levels. And oh, you're doing such a great job. And accidentally they're reinforcing the behavior. It's certainly not because they're bad clinicians. It's just because it's very confusing.
So you wrote a book specifically about the issue of diabulimia women a few years ago. Since that book came out, has the landscape changed at all?
Now, especially in the UK, there's been a number of research projects because the National Health Service put forth a pilot research project at a number of different centers. And they're now at the point where these academic treatment research projects are being published. There's a researcher at Stanford in California here who developed an eating disorder prevention program called the Body Project. And it's a general eating disorder prevention program. It's now been designed and it's being tested at a number of different sites, some in the US, some in the Nordic countries, and some in Australia, called the Diabetes Body Project. So it's now aimed at prevention. And then there's the STEADY study, which is the one out of King's College. That's a cognitive behavioral therapy program for treating eating disorders in type 1. And there's a team collaborating between Duke University in North Carolina and Brown University here in Rhode Island, looking at a different treatment style. It's called acceptance and commitment therapy, and they're looking at the effectiveness of that for type 1 and eating disorders.
You use cognitive behavioral and psychodynamic approaches for your patients. Are you able to give me any examples of what that looks like?
It's sort of an outgrowth of psychoanalysis, which is, of course, originally Freud, which is not anything similar to what I do. But it basically acknowledges that a person's behavior and thought processes and emotional life is rooted in their life's experiences, that everything we experience in our lives has an impact on us and has an impact on how we choose to then respond and how we think about ourselves and the world and relationships. Cognitive behavioral is this idea that our behaviors are influenced by our thoughts and our thoughts are influenced by our behaviors. And you can't really do therapy for an eating disorder or help someone with a disease that's so keenly behaviorally managed as type 1 is without thinking about thoughts and behaviors. So I sort of merge both of those ideas and try to help people.
How can people living with diabetes prevent the development of disordered eating? is that even a possibility?
It has to be a possibility because we need to focus on that. And I think it's ultimately still right now a research question that we're trying to address. I think there's been a huge shift, much of which is a positive shift in the way that nutrition management is taught to people at diagnosis. Carb counting, when it's taught in a flexible manner and not in a carbs are bad, limit them to the nth degree kind of manner, it allows a flexible approach to nutrition, and it allows less of a shame-based, there are good foods, bad foods kind of approach to nutrition. The issue early on with tightening up glycemia and aiming for lower and lower A1C values originally came with a noteworthy weight gain, and that was partly a result of us as a medical field not yet having sort of what I call designer insulins. Now we have a much more tailored approach with these hybrid closed loop systems and also with long-acting 24-hour basal insulins and fast-acting in between insulins. So the treatment itself is looking much more physiologically similar to the way the pancreas actually works. It's never going to be the same, or at least not yet, but it's getting much more tailored, and therefore I think some of people's concerns about weight gain can be alleviated as well. But I think we also need to take people's fears about weight gain and insulin seriously, and we need to be accepting of that concern and help people to feel comfortable with their body size and their overall health.
It's crazy because I feel like it's more normal for women to worry about their weight, and it's so normalized that if you don't say something like, I hate this about myself, or this isn't good enough, then you're the abnormal person.
Right. It's hard to find a quote unquote normal control. You want to have the person with the so-called disorder, and you want to have the normal control by comparison. Who are these people? And I find oftentimes that it's not necessarily that people who recover from an eating disorder no longer have any kind of body discontent or no longer have eating disorder related thoughts. But the question is, what are they doing about them? And I think it's up to the individual to figure out what feels most realistic for them to aim for. Are they really going to be body positive, or do they need to feel more like, okay, this is who I am, I need to accept this is me, or to try to be neutral about it and just be like, yeah, it is what it is.
Well, I think that's a great note to end on. I think the work that you've done in general, it's been incredible. So thank you so much for everything. It was an absolute pleasure to get to meet you.
Pleasure is mine, and it's very nice to meet you too. Thanks so much.